Hello and welcome here live from Vienna. We're in the middle of the Messe Wien, where it's a coffee break at the EAO Congress 2018. During this coffee break, we're going to get you ready as an online Congress participant for the next big talk coming up in our room Wien, which is the Battle of the Concepts, which is all about tooth versus implant. My name is Gerrit Heikoop, and I will be your host for the next 2.5 hours, guide you through this live broadcast, tell you how you can participate, and try to create some context of the learnings that will be presented to you both on stage and here in our online Congress forum. I'm not going to do that by myself. I'm very honored to be joined by my expert co-host, which is Isabella Rochetta from the University College of London, amongst others, and most importantly, also board member of the EAO at the moment. Isabella, good afternoon.
Thank you. Good afternoon to you, and thank you for having me.
How are you feeling at the moment?
Well, I'm overwhelmed by this amazing opening ceremony that we had. I must say the meeting is extraordinary. The venue is great, and I've seen the room yesterday. It was empty. So seeing it today with over 3,900 people walking around, it's quite a special thing.
Exactly, but because you have been at Congress many times,
Yes.
what if we have people from around the world joining us now who've never been at an EAO Congress? How would you describe this experience?
Oh. Well, I think the EAO is an institution. The EAO is, I think, the European voice. Now even worldwide, I would extend it. But it is certainly a place where you get a high scientific level. This is what we're striving. This is the aim year by year, but it started many years ago. And it's keeping the bar very high. So I believe it's an annual, let's say, must go. An annual place where you have to go if you are obviously in the field of dental implants, perio, and so on, because it really exposes you to the high-end lectures and where you can grasp the scientific knowledge. And of course, coupled to that, you have the networking, the people, the friends, and as well the social activities, which are always quite extraordinary.
Yeah.
But I would say that the main area is the high scientific level. And the innovations that we're actually bringing as a board into the live surgery sessions that we are bound to see starting from tomorrow, the focus more on something which goes beyond the sterile lecture of someone on the podium saying, you do A, B, and C, and this is my opinion. This is way something that we're far away from that. So it's more, I would say, an interaction with the audience and the speakers, where you learn more.
Exactly. Now, one of the interactions and innovations is actually this EAO online Congress. So if you just joined us, welcome. We're live from the heart of the EAO Congress in Vienna, and we can make this interactive with you as well. So we're very curious. We're on Facebook. That allows you on your keyboard to let us know who you are and where you're watching us from. Do that right now. And if you know anybody in your network, either a dentist, periodontist, anybody interested in implant dentistry, make sure you hit the share button. Share it on Facebook, share it through email with your entire institution. Make sure that everybody gets ready, because 3:15, you're going to learn the latest and the greatest in diagnostics, and more specifically in tooth versus implant. Because, as you say, it's not a standard clean lecture. We're going to see a battle of the
Yes.
concepts format.
Yeah, but
For
as
those
you,
of them-
as yeah, you're right,
Yeah.
because as you said, even just the fact that now we're live on Facebook allows a lot of people who could not come for logistics reasons, for many reasons, to actually kind of have a taste of what the EAO can offer. So I believe in the education and spreading the education everywhere. And we are lucky because we can be here, but the fact that the EAO is allowing this to happen over the spread of the 3 years, then that's brilliant.
Yeah. Now, you're also a member of the EAO board.
Yes.
Yesterday, you had a big board meeting. What is on the agenda strategically for this association?
Top secret. No, I'm joking. No, as I said, I am head of the communication. So I specifically look into everything that could be changing the way, the perception of our members. So to us, the members are the most important. So funnily enough, it's not necessarily to increase the number of members, but to actually give more to the existing members. It's a big, huge family.
Yeah.
And we like to have controllable numbers, if that makes sense, because we can actually reach the members and we are all in the same boat and give them some benefits that we all would love to have. So we have several activities open to the members. We have the online library, which I believe is an extremely useful tool to gather information, to improve yourself every day.
Because what can professionals find there? If I'm an EAO member, I go into the online library. Then what?
You can download all the scientific information, which will, according to your needs, which will guide you to then treat the patients better. So everything is done so that the professional has access to the high science, basically.
Yeah.
So it's almost like, bridging the gap.
Yeah.
And not only from the library, we are organizing the educational activities. Educational activities have been very successful. Imagine having, a 3-year program with a hat of the EAO that that you will receive instructions from the best institutions around Europe.
Yeah.
So that alone is something special.
Yeah, because this is let's be specific, this is the 3-year postgraduate education program.
Correct. And very proud to say that yesterday we announced that we have sold out the next class.
Oh, that's a pity for our online viewers.
Yeah.
What if they want to join? Is there going to start a new program?
Yeah, of course. I mean, year by year. So we sold out the upcoming entry, but it's extraordinary. We have the master clinician courses. So we have a 2-day intense program where you visit one of the leaders in our field and you really dig into that specific topic. And again, it is all done in small groups to ensure the high quality of the teaching. So, these are just examples. We are really working on an array of different opportunities. And again, you can see that the theme is always the same. Improve the science, the knowledge, and the clinical skills, and broaden this to everyone.
Exactly. Now, out of personal curiosity, I can imagine that being active, very active in several academic fields, being active in clinical practice, also being active in this association, I can imagine that some people think, well, a 3-year postgraduate education program, how am I going to find the time? How do you personally organize that?
Well, this is a very, the 3-year program is obviously not a full-time program. It's an extremely part-time program. So the beauty of it is that you travel throughout the different countries and there are specific timelines. So it's not, from a timing point of view, it's very straightforward and easy. The good thing is that then there is a network that is kept amongst the tutors, the instructors, the professors, and the alumni in order to enhance throughout the time frame that you are at home doing your own things, because we're all clinicians. We work on a regular basis every day, long hours.
Yeah.
So that allows you then to catch up and to carry on. So it is absolutely feasible, that specific one. But then, as I said, we have different opportunities to do everything.
Yeah, so it's a strong combination between the physical live educational events, networking events, and the online publications that are available.
Correct.
Well, and I bet some people have just only recently joined us, so if you did, welcome here. We're live from the middle of the messe. We're here at the forum, the EAO forum, where we're looking forward to a session that is about to start in the main room, the messe, or the Vienna room, which is called Battle of the Concepts, Tooth versus Implant, and we're going to look forward to that in a second. In the meantime, if you're joining us, let us know who you are and where you're from, because this is live, this is interactive. If you have a question for Isabella, if you have a question to the speakers, make sure you enter it in the comments. Now, Isabella, one of your tasks is also that you're a co-editor of Inspired. We have it here in front of you. Let me take that up. It's a beautiful magazine. See if we can see it. It's called The Alternative EAO Voice. Can you tell us a little bit what this is?
Well, I co-edited this with my dear colleague and friend David Nizant, who's from Paris, and we had the idea to be a little bit alternative. So we have a very high-end scientific journals, including the COIR, as we call it, clinical oral implant research.
Yeah.
I should be more specific, which is an extremely high-ranked scientific journal, which, by the way, we have now the proceedings of the latest consensus conference, which we had in February in Switzerland, with the latest systematic reviews of the highest, high-end topics that we had selected. So I encourage all the followers and the readers to go and take a copy of it, because it's extraordinary. And to add to this, a fantastic group of Spanish dentists have translated the scientific knowledge into clinical tips. So we have then an abstract, let's call it abstract, even though it's more than that. It's a summary journal of the scientific papers with a very practical implication to them. So the clinician can easily flip through the pages and gets the ultimate, research. It's, for us as professionals, when we treat our patients, it is absolutely mandatory, I would like to say, to be ethically up to date. You have to know what is going on. And this is the reason why we have created this, I would say, special journal, special edition, which is a clinical translation of the findings of the consensus conference.
Exactly, and I should direct our viewers to the EAO website, look at the section publications, because as of today, fresher than this, it's not going to get. This publication, this digest of the key findings and the key implications for clinical practice are available for download in 9 different languages. So not only in Spanish and English, but actually in 9 different languages. So there should be something.
Chinese as well.
In Chinese as well. I haven't looked up all the languages, but I bet
think
Chinese
it's
is there.
Chinese as well, which is extraordinary, because China is one of the 4 countries who majorly represent our guests.
Exactly.
Which is extraordinary.
Exactly. And I think it's relevant because I see some viewers actually interacting with us. We have Taratip Veerapan, who says, hi, Superachai 555. We have Alan Chavanas joining us, says, hi from Paris. And, here, Taratip is from Chiang Mai in Thailand.
Voila.
I'm not sure if the publication is in Thai yet. We have some other guests. Those are the first 2. So if you want to make it into our broadcast live, make sure you hit our comments right now. We'll read out your wish for this community. And later on, you are also able to send in your questions to our speakers, because this session on stage is going to be live, it's going to be interactive, and after the session, the speakers will come here into the into the forum to actually be available for you exclusively online to take all your questions. It's an Ask Me Anything only for you, so stay tuned for that. Now, you started talking about the digest publication, which is something else than the Inspired. So what is the Inspired publication?
So as I was saying, Inspired is a different voice. So I started by saying that we have the scientific journals. We wanted to create a journal for the clinicians. So everything that is in here, in fact, is clinically driven. So the clinician who cannot have access to university settings, to multi-center studies, which are obviously, a burden. However, they are excellent clinicians who want to, in a way, discuss their findings. Well, they can send us a paper, and we have a very strict review process. We're all clinicians in the board, in the editorial board, and they are then published as pure clinical cases. But not only, we have a section which I really love, which is the tips and tricks. So it is asking the experts on the tips and tricks of a specific, for example, procedure, which rarely you can find printed. I mean, normally you can have a verbal conversation during one of these meetings, during a coffee break, for example, during a gala dinner, but it's very rare to actually. We all work, right? As we said, we're all clinicians. When on the Monday morning you're faced with a problem, you scratch your head and you say, damn,
where are you gonna go?
Where do I go? And you would love to have 10 different friends around you to express. So this is almost like a platform where you can put your questions. And we have the paper format, as you said, the printed version.
You're pointing at the paper format.
And of course we have the online. So
and that's an interactive platform where I can also go online and post questions.
You can go online, and it's not yet an interactive, but it will get there. However, you can obviously put down all your cases and everything. And then of course there are the news of the EAO and the EAO family. So the winners of certain certificates and tips of the upcoming city where the meeting will be held. It's really got an array of different different information. we wanted to create something alternative. That's why
That's
it's
the alternative.
the
That and
alternative.
that refers to that it's clinically based and
Yes.
not specifically academically based.
Exactly. So it's clinically based from clinicians, made by clinicians for clinicians. So I think the strength is there.
Cool. So where do I go online if I want to check this out?
Anytime. You can
Anytime. So
go-
I Google inspired, which
Yes.
is spelled. We should
With a Y.
spy, eh? Inspired, because it's
Spire,
looking
like a
inside.
spy. Yeah, we're
Exactly.
spying into the everyday world. But of course, I mean, for the members, you can even go on the homepage of the EAO as a member and log in, and
Okay.
then you get this. Yeah.
Well, talking about spies, welcome to anybody who has just joined us. I see some of you very actively tagging friends and colleagues in the comments, and that's a good practice we like, because in about 10 minutes we're going to transfer you into that main room where you are able to follow live online the Battle of the Concept session, and we want to make sure that as many people benefit from this as possible. So Aisha Ouache, I hope I pronounced your name correctly, thanks for checking Abdelhakim and also checking Hamu. And if you're just watching that and you haven't done that so, please hit the share button or tag people who you think you should join. And if you have any questions, let us know in the comments right now. Because let's look forward to that session,
Yes.
Isabella. It's called Battle of the Concepts.
Yeah.
Before we go into the content, why do we need to battle concepts in the field of implant dentistry?
That's a very good question. I would like to ask you why now. Well, the battle of the concepts, because we are faced with a point, as I said, on your Monday morning when you have a case. After having gathered all the diagnostics of the case, of course, and after having digested the case, you have to come up with a treatment plan.
Yeah, what are we
That's our
gonna do?
job. What are we going to do? And in fact, the question is, do I save that tooth or do I replace it with an implant? Now, obviously, if we get the extreme cases, it's a no-brainer. There are specific indications for A and specific indications for B. Now, I hope that the speakers will address the gray zone, the zone where there are factors pro keeping the tooth and factors saying, well, if I invest, biologically speaking, in this tooth, in the treatment to save the tooth, then is it going to be worth it? Is it going to last for X number of years? We cannot provide patients with therapies that last for 1 year. This cannot be done. So
Exactly.
where do I stand for the long-term maintenance? That, I think, is the gray zone.
Interesting.
And there are various factors which I hope we will see, and I'm looking forward to having two eminent speakers as we have, because I believe they are probably the godfathers in our field.
Yeah.
Well, Klaus Lang definitely
Yeah.
is, by knowledge, by experience, by culture. So I am sure that we will learn massively. Obviously, you know, the question is, which I always pose, you know, as a teaser, if it was yourself, or if it's your daughter, or your husband or wife, what would you choose?
Yeah.
And I think each one of us has to treat their own patients as if we were treating ourselves or a very close relative.
And from that perspective, if you take the patient perspective, which we learned this morning is very important in this
Yes.
Congress, where would you be inclined to go in the gray area? Would you always try to stay as much as possible to the preserving the tooth?
Well, naturally. I mean, everything that is possible. We have a very solid scientific literature that brings us extraordinary results with, let's call it conventional, but, you know, well-performed periodontal therapy or dentistry
Exactly.
to save the tooth. So I tell you for sure that when you can even vaguely save the tooth,
Yeah.
we're obviously talking to the public, so I need to
Yeah.
you know, express myself in a very simplistic manner, then it is obvious that this should be done.
Exactly.
Because
And the
there's
question is, so what is driving the movement to actually say no? Because there's another side to this battle, which
yes.
says no, you should go all on implants.
Well, all on implant is a big word because I sadly see a lot of, you know, full arch cases where all the teeth are extracted, even the good ones, because there are only like 2 or 3 within the whole arch, and then treated with implants. Now, if we talk about specifically one side, so not to broaden to a full arch, because the topics
Yeah.
are very different. If we speak about one side, well, there is one clear indication where there is nothing that we can do to save the tooth, which is the axial movement. Now, in technical, I'm not sure if you.
No, let's go for layman viewers. So the axial
Okay.
movement,
The
yeah.
axial movement. So in fact, when you have a mobility of grade 3 and the tooth is actually moving in a vertical direction, then there are there are solid literature background that tells us that sadly there's very little that we can do.
Exactly.
So in that sense, you're lighthearted. As I always speak to the patients, and this happens every day, you try your best to be able to find a solution. But there are moments when you have to know that the line, you have to draw that line, and you have to jump on the other side, and you have to say, if I do something, whether it's a periodontal treatment, whether it's an endodontic treatment, whether it's prosthetically driven, then I may give him a failure very soon. So maybe that's the moment when you have to call it a day and
go
opt
all
for
on implant.
yeah.
Yeah. And what do you say to people who argue that, wait a second, it's not much use to invest, also from a patient perspective, in a failing tooth anyway? Because yes, we can do periodontal therapy, it's lengthy, patients have to come in multiple times, and maybe in the end we end up anyway. So why even bother? Just be quick and get it over with, go for the implant.
Because if we have this reasoning, I mean, if this is our mentality, then you end up extracting too many teeth that could be saved. And at the end of the day, there's nothing like your own tooth. Even a compromised tooth, there's nothing like your own tooth. And you can ask each one of the implantologists. I'm an implantologist. Well, implantologist is a wrong term, by the way.
Yeah. An expert in implantology.
Whatever, whatever we want to call ourselves. But anyway, people performing implant dentistry, they will all confirm that at the end of the day, dental implants are an extraordinary discovery. They have changed radically the well-being of the patients. But there's also been, on the other side, people abusing the use of them. So we have to be extremely careful. So
and when you say the word abuse, you mean?
I mean, as I was mentioning, extracting too many teeth,
too
quick, too much, all in one go, making everything look very easy.
Which it's not.
Which is not.
Well, and with that, I think I would like to hear your point on this as well. Where do you stand in this battle of concepts? Are you, when it comes to the gray area, of course, are you more on the there's nothing above a human tooth, you should preserve whatever you can? Or are you more on the side, let's get it over with, I'll go all on implant? Please let us know in the comments right now where you stand, and let's have a little battle of concepts here on the side virtually. Just going to make a quick shout out to Niranjan Divakar, who says Guten Tag in German, which is the language here. And we have Klaus Hucker also joining us. I can't see where you're from, Klaus, so let us know in the comments. So thank you for that. And while we're at it, if you're watching from anywhere in the world, later the session will be interactive as well. There will be clinical cases presented, and the audience will be very interactively asked to vote by multiple choice question on which treatment or which diagnosis they would think would be best. And you can actually participate in that remotely as well. What you need to do is get out your mobile, go to your App Store or Google Play Store, Android Play Store, and look for the EAO Congress app. It's a free download. You download the app, you search for the session that's going to take place in about 10 minutes, or 5 minutes actually, we're about to start. And once you're in the session, you see the multiple choice questions right there. And once they come up on screen, you'll be able to vote and participate in that as well. Beyond voting, you can also send in your questions, both to the stage and to us here in the forum, because the speakers, after they're done on stage, will come to the forum and will be here exclusively for you online. So you can use the Facebook comments for that. So, Isabella, looking forward a little further. What is the key thing, if we translate it to clinical practice, that's what you do with Inspired, that people could take away from this debate? What do you hope people can learn for the clinical practice?
I sincerely hope that time will be spent, which I am 100% sure, knowing the speakers, time will be spent on the diagnostics. So the key is, as we said before, diagnosing the patient, the case, at a 360-degree version. So you really want to get into the pros and cons of both options, because the risk factors, you have to encounter everything that then will lead you to the choice which hopefully is the correct choice, the dilemma. I like very much the title Battle of Concepts, but in fact, on the other hand, it really depends case by case. So we will have Klaus, I am sure, Professor Lang, showing us extensive research behind every decision. This is how we should all work. So we should start our patient journey in terms of treatment planning by having evidence-based, which doesn't necessarily mean only relying on systematic reviews, for example. That would be a mistake. But you have to combine the systematic reviews with the experience and possibly even your own mistakes. So I think that the combination of factors, experience, your own mistakes, learning from the people you obviously you really believe in and you trust, plus all the evidence-based, then brings you to another to a different level. So I'm really hoping they show us the diagnostic process and they factor in all of these things.
Exactly. And if they don't, the beauty is we have them for
We have
ourselves
them here.
right here in the forum.
And we will ask them.
And we will
Yes.
definitely tackle
We
them.
will ask them.
So we're about to get started
Okay.
in the main room. So if you're just joining us, for the next 90 minutes, you'll be live in the room, but stay tuned, because after that, we have the speakers here in the forum together with me and Isabella. Enjoy and see you in 90 minutes.
So, good afternoon, everybody, and welcome back to this huge auditorium. We have a very interesting session this afternoon, and I have the privilege to co-chair with the big boss here who organized everything, my dear friend Bjarni from Iceland, Bjarni Pjetursson. And we are following on the path of keeping our patient at the center of the session. And the debate today would be all on teeth or all on implants. Bjarni will tell you how this session will work. You will have an opportunity to vote, and we will see how the audience is receiving the cases that will be presented by the two speakers. So Bjarni, please.
Yeah. Thank you, Luca. It's a real honor to chair this session with you, and good afternoon, dear colleagues. It took me about 5 minutes to figure out how to vote during the session, so maybe you should already familiarize you with a little bit, because during those 90 minutes, we are asking for your opinion on the treatment option 7 times. 7 times. So you have to really follow us a little bit, so that we don't invest too much time on this. And to be able to vote, you have to go to the EAO app, you have to find the session, and then you have to find the speaker, and it is under the name of the speaker where you can find the questions. So I think you are all very talented people, so you will figure this out. It took me about 5 minutes, but I am a bit slow. So we are not going to spend more time on this. Today we have really 2 distinguished speakers, one from Germany, Professor Wachtel, and another one from Switzerland, Professor Lang. So we are going to make this session in the German language.
Hey,
I think it's fine for you.
and what about me?
Or not for you.
Oh,
Sorry. So most probably, just because of Luca, we are going to make this in English today.
okay, okay.
So I would like to introduce the first speaker, a really good friend of mine, my tutor since ever, Professor Klaus Lang from Bern and all over. So Klaus, please, the stage is yours. And we are going to...
A warm welcome to Professor Lang.
Thank you very much. This is, of course, a great pleasure to do this with my 2 friends here and my adversary over there, because we are supposed to have a diagonally opposed different opinion. As so many things, you will find out this is not really the reality, but maybe it is the dream of the organizers that we start fighting here. So my position is the position of the one who tries to do all on teeth. And in order to do that, I have to go back some years, because when we didn't have implants, or we didn't use them yet, then we had only teeth. And I show you here a tooth in the year 1984. Now I could do a first vote and say, who of you is going to extract that tooth today? Who is going to save it? I will not do that vote because it takes my punchline. At that time, we did not have any choice but to maintain the tooth, or the patient would be edentulous in one jaw. So, my God, what was done here is that we, of course, treated the tooth periodontally by extracting the mesial root. But the interdental septum was completely full of bone, and distally we did a root canal treatment. So we hemisected this tooth, and as you can see then, we built it up. And it was a perfect abutment. And you will say, yeah, for 2 years. Well, this here is at the beginning, and this is 30 years later. So the question is, was this tooth, this therapy successful or not? I think you have to admit it was. So all on teeth worked, even when the tooth was jeopardized and didn't have enough substance and so on. But I must admit, it did not always work like that. But then I show you another case, and this case is a little bit more challenging. This lady has lost in her summer vacation a tooth here. And that happened in Sweden, where she went to the dentist, and the dentist said, my dear lady, you have periodontitis. You have to improve on your oral hygiene, and I think she did. So you can see it looks like that, and what you see, the stain here, is chlorhexidine stain. So she came back to Bern with a treatment plan in her hands. And as you can see, this was 1977, way before the implants were here. And we had to use the teeth. So we did use the teeth. And, but I ask you now, when I show you this dentition, look here, you will have a lot of attachment loss. You have attachment loss to the apex in the front region. This is the tooth that came out through an abscess. You have furcation involvements and so on, and the similar picture in the upper arch. Now I show you, of course, the confirmatory radiographs, and you can for yourself make now a little thinking. How would you reconstruct this patient today, when you have to reconstruct the patient? You have all the ways and means. You have implants, and my question is therefore, how would you restore the lower jaw? The lower jaw only, let's concentrate on the lower jaw, with all on teeth, all on implants, or with a combination of tooth implant supported restorations.
So now we need your feedback for the first time. It was quite a nice situation for Professor Lang, because usually our patients do not show up with a treatment plan. So she came with a treatment plan from Sweden.
Yeah, but I didn't say that yet, because I don't want to
No,
bias
you're not
them.
going to spoil the party by telling them what was a treatment plan.
Yes.
But the patient came with a treatment plan.
Yeah.
So now we need you to go to the app and give...
And please let me tell you that you can also use the app to raise questions that then we will give to our speakers. And one thing more that I think is very exciting, this whole session is broadcasted on the internet via Facebook, so we have a live streaming on Facebook, and we want to welcome the people that are abroad everywhere, and that we'll also be able to present questions.
Klaus, I think before we close the voting on the lower jaw of this lady, maybe you have to convince them a little bit to go for teeth.
I have to convince whom?
The audience, because they have to make up their mind.
Of course, and I can second that now with a statement that she came home from a very famous dentist who has published a lot on that, Dan Lundgren, and Dan Lundgren proposed to her a full arch bridge.
See if it works.
He said, well, we can maintain one root here and make a 3-unit bridge to the first premolar, and then a second bridge from the canine to the other canine and to the first molar again. So basically there are 2 bridges. Everything is built on teeth, and that should work. Now, this is the secondary information you have, and you see my bias. Obviously, I had to do that then.
Okay.
And because having this treatment plan, I could take the responsibility. Well, somebody else has helped me, and I know this guy very well. Now, the question is, would you do the same today?
Klaus, let's have a look.
Now we have to see what the audience selected for this lady.
Oh, wow.
Aha.
1 in 5 of you does it on teeth. 21%. Very good.
Okay.
A third, 1 in 3, does all on implants. That means you remove all the teeth, I guess. And some do both. Now we will discuss that in detail.
Should we move to the upper jaw now, Klaus?
Yeah, well, I want for the upper jaw, let me go. I have done here some mistake. That was, yeah, we go now to the upper jaw, and on the upper jaw, I will give you some more information.
Klaus,
Yes.
may I say something about the first voting? It is clear that the title of this conference, of this session, is All on Teeth versus All on Implants, but it's very difficult in our profession to state that something has to be white or black.
Yeah.
There are always possible combinations and different approaches.
For the second part, second question, we address the upper jaw. And what I show you here is signs of bone resorption as a result of multiple steady trauma from occlusion. You can imagine that these teeth, whenever the partial denture was placed, they were moved back and forth. So you have here an additional trauma from occlusion, and I must add to that, the pockets do not go into the pocket. It is trauma from occlusion. So the same question now comes. How would you restore the upper jaw of Mrs. UW, all on teeth, all on implants, or with a combination of tooth implant supported restorations? I must also give you, again, the secondary information. Dan Lundgren, who made the treatment plan, said to Mrs. W, the upper jaw is too late. We're going to do suggest a full denture. So that's the background. Now, please vote.
Now it will be interesting to see whether we will get different outcomes on the upper jaw, because there were like 45% of the audience would have a combination to restore something on teeth, restore something on implants in the lower jaw, but upper jaw might be different. Should we try to see how the audience, what would be their preferred treatment plan for the upper jaw?
Yeah.
You see, there is a major shift here from
only
22% to 71%.
only every 12th of you is courageous now. And 71% do everything on implants. Obviously, because you got the information that the treatment plan was also towards full dentures. Now, when she was treated in the lower jaw with a full arch bridge, and it worked very nicely, then she told me in the end, now I want the same in upper jaw. Now this is the patient who had a desire to maintain her teeth. What we did is a pre-therapeutic prognosis, of course, and I have crossed off here the teeth we can no longer save. We have already talked about the lower arch, but then you have in addition the upper arch. And you see that these teeth, the molars, had furcation involvements, and the palatal root was in granulation tissue. So the palatal root had to be extracted, and there were 2 buccal roots left. And still, we then realized that these teeth were in trauma, and we kept the 2 buccal roots, we kept the canine, and we kept the central incisor and the canine there. 5 roots. And we did all on teeth, because the patient absolutely wanted that. Now, you can ask, well, for how long did that work? Did you sleep well at night when you have done this? And I show you here 78, this is 2 years later, the reconstruction in the lower arch, complete when she said, I want in the upper arch the same thing, and so in the upper arch the same thing was done. Now we go further. This is 1996, that's 18 years later. Now don't think that she died at this age, but this here is 30 years later, almost, 29 years later. And when we look at the period chart, 29 years later, very few abutments, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, very reduced periodontium, and yet healthy. And therefore, I think we could say, I want to show you what is possible with healthy abutments, even if the height is not dramatic anymore. So this is severely reduced periodontium, and today such teeth are unfortunately extracted quite often.
Klaus,
Yes.
may I ask a question? Do you think this kind of treatment works in the hands of the average clinicians? Or do you think that this is something that would rather need super expertise?
It depends on what you define as the average clinician. I think it depends on how they are trained. And I can guarantee you that it worked in the hands of every graduate student who came through our program in Bern. But these are not, they are not Mozarts of dentistry, but they were trained the right way. The approach was an antimicrobial, and when people learn how to treat the periodontium, they can do it.
That's a very good answer. Thank you.
Oh, thank you. But I'm no longer in Bern, as you know. What the question I would have expected from you is, would you do the same thing today?
Well, before that, I have another question. What about the aesthetic outcome? Do you think that this is something that we can offer to our patients nowadays? You have a 50-year-old
Well, you have
lady.
seen the aesthetics. It's nothing to write home about. The aesthetics is lousy in today's standards. But it depends, of course, also on the lip line, on the smile line of the patient. It depends on what the priorities for the patient are. Quite often, I mean, we see aesthetic cases in young people, 20 to 30 years old, like also this morning, maybe a little older, and it is 1 or 2 teeth. But when you deal with a dentition that is shortly before falling out, then the aesthetics cannot be the way it used to be before. You have to realize that you have lost a lot of tissue, and that is the way it is. When you have an amputated man who has lost his leg, you cannot grow back that leg. So one has to do with the prosthesis that you can come to an illusion close to nature, as close as possible. But I must admit, this is not an aesthetic solution. If aesthetics are a priority, it's a full denture.
So we have a question from the audience, Klaus. What about combining teeth and implants into the reconstruction? For example, if this tooth could not have been saved, would you consider having one implant here and then do the same type of reconstruction?
In this case, where I had abutments around the arch, there are only 5, but they're nicely distributed. I would not jeopardize these biomechanics with one implant, because the moment I incorporate an implant in the reconstruction, the whole biomechanical concept changes, because the implant now carries the whole load of all teeth. It's ankylotic. These teeth were mobile. They were mobile. Once they were splinted together, they were less mobile, but the bridge was slightly mobile. And you will see the results over time. Actually, this improves the long-term prognosis. It gives you less technical complications. So just for one tooth, I would rather not do it. But if you want to combine and make smaller segments through that, then it's another story.
Okay.
Okay, I think we have to move on to
Now,
other
let me
cases.
allude to this a little bit more, because before implants, treatment planning was done in most prosthetic departments according to Antes law. And I call Antes law the biggest crime in dentistry of the last century, because it made us overdo things. It forced us into cutting preparations in teeth that should not have been cut. Antes law basically comes from an opinion of Ante, who published this in the Michigan State Dental Society's bulletin, a journal that is long disappeared, and it explains that the total periodontal ligament cell area of abutment teeth should be equal or exceed that of the teeth that are lost and replaced. So when you look at Antes law, you can, in an atlas, find out how many square millimeters does, for instance, a central incisor have in the maxilla. It's 204, and the lateral incisor has 179. So you see this is 10% more. So you see this is the least amount of a tooth normally without periodontal disease. And you can see the central incisor has 10% more, the canine has 50% more, the premolars have 30 or 20% more, and the molars have 2.4. This does not consider the fact that the molars have, of course, furcation problems. But when we look and calculate that now and do the same thing for the mandible, where the central incisor has the least amount, then we can now ask the question, is Antes law justified? And there is not only that case I showed you, but there is also something to be considered, and that is, as I lose attachment, I move down on my attachment from 100%. Here, the distance from the cement to enamel junction, let us say I have lost 5 millimeters, and then you can see this gives me only 50% of the attachment. In other words, once I have periodontitis, I lose substance, I lose attachment. And if I consider that, it doesn't take too much to say that this bridge has too few abutments. But as I said, this is not the truth. There is one article, and I would like to show you this because it's a unique piece of work from the Neumann, Ericsson, Linde Group and Lundgren, where they analyzed 60 bridges out of 250, and they calculated exactly the total periodontal ligament area of the abutment teeth and the teeth to be replaced. And here is a case, just an example. You see, here the tooth 46 is an abutment tooth, then we have 43, then we have 33, then we have 35. 4 abutment teeth. Now, if I add all of this together, I come to 805 square millimeters. And now I will calculate all the teeth that are replaced, 45, 44, 42, 41, 31, 32, and 34. And I come to a total of 849. Now, you can see that exceeds this amount, which means you could not place a bridge, a fixed reconstruction. But it is much worse because they have lost attachment. They've lost 30, 70, 50, and 60%. So that has to be accounted for. And actually, we have only 428 square millimeters to support 850. And it's quite clear that doesn't suffice Ante's law. Now, these bridges were analyzed in a way that you have here those who fulfilled Ante's law, and these all did not fulfill Ante's law. And you see it's 5 out of 50 bridges. The other ones all did not even, and the case I showed you belongs to this group. But what is important is here at the start of the insertion of the reconstruction, and 11 years later, the bone scores were exactly the same, no attachment loss, meaning longevity. Now, in summary, we have 60 FDPs, we have an observation period of up to 11 years, 8 to 11 years, and over 50% did not comply with Ante's law. That means of the required periodontal ligament area, and no loss of attachment or bone loss. This shows you that Ante's law is an illusion. It may have been a dream, but it is really not reality. So if we want to really be sure that there is not an article who would support Ante's law, we go to the literature, and our group has done about 14 systematic reviews where we use the microscope to read the articles correctly. And when we did this analysis more recently with Martina Lulic, and we called it Ante's Law Revisited, a systematic review on survival rates and complications of fixed dental prosthesis. I want to show you the results of that systematic review. Here we have the dental literature of the last 40, 50 years covered, and every study that we could find. And we have survival and complication rates for 5 and 10 years. Now, out of 860 articles that were retrieved electronically, we end up with 6 studies in the end that we can use to answer this question. It's a total of 579 of such bridges on very few abutments and reduced periodontium. Follow-up up to 25 years, and this is now the total literature. And believe me, since 2007, there has not been one single article on that. And the outcome is very good. After 10 years, the survival rate is 92.9%. That's quite good. After 10 years, you have 93% without any endodontic events, and you have 98% without caries, and you have 95 without loss of retention. Now I put this in perspective with all the other systematic reviews that we have done in Bern under Bjarni Pjetursson mostly, and I only draw your attention to 10 years outcomes. And you can see there are clearly modalities like the conventional bridge, 89.1%, or the implant supported bridge, 86.7%, or the single tooth implant crown, 89.9%, that are the preferred from a survival point of view. There are somehow a little less survival rate, like the cantilever bridges, 81.1%, and that adds to the question that came in the app, 7.8 for mixed implant tooth supported reconstructions. So it's clear that this is a second priority reconstruction. And I would not choose that deliberately unless I had to. That answers probably the question. But what I want to draw your attention is this last figure here, 92.9. These reduced periodontium, few abutments teeth, have the highest survival rate of any reconstructions. Isn't that surprising? I wanted you to realize that you can believe in a healthy periodontium, and you can build on teeth when the periodontium is good.
So I think with this, you have, Klaus, you have answered several of the questions we have been getting from the audience, because they were not really convinced, because they thought the case you showed was just like a unique case.
No.
But you show if you do it in a correct way, that then you get really, really high survival rates. And then there is a little, also we have got several questions about how can you really get the patient that has had those periodontal problems into changing their way of cleaning and motivating them. But I think we keep this question maybe open until the end.
Yeah.
And maybe simplify it. Is it different if you use implants? Can you then totally ignore this factor?
No. I think you need to change the paradigm of a patient. A patient who comes in with lousy or below average oral hygiene needs to realize why he has lost attachment, why he has gotten caries, and he needs to be instructed, but in a way that he changes his paradigm. It's like a smoker. When you try to tell him to stop smoking, you have to motivate him, and it doesn't always work. That's sure. But keep at it, and quite often you find out that during the course of treatment, or maybe even a year or two later, they change.
So
I have, from Bern, we had about 30 such cases, simply because they're very expensive. I mean, there is a limit to what people can pay. But I would like to end my presentation with this last title, Mutilation of Periodontally Affected Dentitions. I've chosen that title because of a case where I want you to tell me what you want to do. I show you here a case. This case was presented in Singapore in a combined prosthodontic periodontal seminar. Every Monday we had these seminars. Once it was a prosthodontist, once it was a periodontist who presented the case. And of course, they were very proud to have a case, and so was this lady who had treated this patient. Now, this patient showed us this case. She was dissatisfied with the fact that you have an elongation of this tooth here. As you can see, the gingiva is absolutely perfect. The bone level is absolutely perfect, and the periodontal pockets are absolutely perfect. Pockets of 1, 2, 2, 2, 2, 3, 1 millimeters. So we cannot have it better than periodontally healthy. Endodontically, both teeth 44 and 45 react positive to the cold test. Electronic pulp testing also. No percussion sensitivity and no sensitivity to palpation. So this is a healthy tooth, but the prosthodontist is disturbed by the fact that this tooth is elongated, and it disturbed the lady because of the opposing arch.
So
Now, I have the questions for you. What do you think? What would you do? Would your preferred treatment be for this lady? An occlusal reduction, A. Restoring with a crown or an onlay, B. C. Endodontically treat and restoring with a crown and an onlay, or D. Extract the tooth and place an implant and implant supported single crown. Please vote. Now, no more secondary information as before.
I don't think you need so much time. It's only one tooth to make up your mind.
We're only dealing with
take
one
all the
tooth.
time you need because, like, you're not supposed to make important decisions.
While they are voting, so for you, Klaus, and I think for everybody in the audience, you should be clear that the key factor here when we're talking about periodontally compromised patient is the control of the infection. Whatever you use, the teeth or the implants, you have to be sure that the patient changes attitude. Would you agree with that?
Yeah. Okay,
Okay, should we see?
show us.
Are you going to make the sound like more exciting? Dum, dum, dum.
You want more votes?
We need music, please. No.
Okay,
Here it comes.
interesting. Huh, nobody voted?
Or the system did not work. Because
Either the system is broken.
I expect them to have taken a decision.
Can we repeat that? It can't be that nobody voted.
But
The problem is this tooth with an elongated
No, we are totally
crown by 1 millimeter.
here, I think.
What would you do? What does modern dentistry do today?
that's a very interactive thing. Okay, let's go back to Klaus' presentation.
Hast du,
Yes, you have to find it here, Klaus.
hast du gefunden?
No, because when I
It's stopped.
And now.
because I don't use this thing.
Is dat een ding?
PowerPoint. Ja, wir machen einfach.
Aber wir haben nicht den gehabt. Das ist der falsche Auftrag.
Aber du bist bei Kino gewesen.
Ja, ich bin Kino.
Whatever you prepare and however you prepare, technical issues
Here we
always
are.
there.
Back. Now, vote again, please.
I think they already voted, but the technique is maybe not working. We try again.
Let's see.
You see.
The winner is none. It's
Okay.
0%.
Okay.
Okay.
I think you're all right because you didn't do a thing. You can defend that. You can defend that, but this is not what the lady did. She presented that as a final case of her graduate program after 3 years, and was so proud that she took out the tooth. You know, she took out the tooth, and then when she took it out, I asked her, have you looked at the attachment of that tooth? And she said, yeah, but it disturbed the occlusion. And I said, well, now let's analyze that. We looked at the root, and we stained the root with toluidine blue. We could identify the level of attachment. And I found out there, I measured the whole thing, 60% of the periodontium was still there. If you don't believe it, you can also look at that from the radiograph point of view. You have there, of course, a line, that cement-to-enamel junctions. 1 millimeter below, you have the attachment. So you can see how much was lost. That's 40%. And she says it's periodontally diseased. The tooth has to come out. And then I placed an immediate implant. Of course, money, money, money. That's nothing else. But then things went a little bit wrong. She had not enough bone there, so she placed augmentation material, and then, you know, just to say that this is really healthy. Now, the implant was placed. You see there is a missing bone. She augmented. Then came an infection that she did not take a picture of. But the infection made that one had to clean the whole thing out and redo the stuff. So in the end, you have adhesions. Never mind. Now, she augments this. Think of all the costs in between. And finally, she closes that and she places the reconstruction.
They still didn't vote.
And the reconstruction, in my mind, looks more like a strawberry than a tooth. And I now told her, now look back to the original situation. Is that the treatment we should pursue? No, certainly not. And it ties in with teeth with 60% bone left, or 50, or even 40, are very good abutments if you need them. And it is, of course, clear that you could have reduced the occlusal plane by 1 millimeter, with or without an onlay. Probably without. With this, I would like to say, when we do discuss all on teeth or all on implants, it's probably never black and white. But give teeth a chance. Here, I'm going to sing on Friday night in the Viennese States Opera. You can come and listen. I'm going to sing, all you are saying is give teeth a chance. Thank you.
So if you want to hear more from Professor Lang, he is going to play the main role in the opera tomorrow evening. But then he will not be discussing about teeth. And after the session, because we got so many questions from the audience, they will be interviewed in our digital village, and then you will also have online, because we could not address all the questions you sent.
So you can continue to follow the discussion later on with the Facebook streaming thing. Please,
Thank you.
Hannes.
Thank you.
Now we have
Thank
the Munich approach.
Yeah.
Let's have a look.
Good afternoon, ladies and gentlemen. It's a real pleasure and honor to be here and to discuss with you and meeting Klaus on the battlefield and discuss different treatment options for the sake of our patients. Now, to start the battle, I would like to ask a very simple question to all of you. When is the implant the better tooth? Never, sometimes, or frequently. To acknowledge that, we have to see that the answer is a complex answer. We enter a complex system. There are a lot of interdependent feedback loops in order to find the right decision. Now let's apply that in your office. And you come Monday morning in your office, and you will find these 3 patients sitting in the waiting room. Irene, 35 years old, rather young patient. Fred, 42, male patients, and Herbert in his 60s. And they all complain. I want to have new cheese. I cannot chew anymore. Let's look and ask Irene, what is your main complaint and your main wish? And you see, for years she had problems with her teeth. And she's desperate. This bothers me more and more, and I would really would like to have a new teeth, and especially new fixed teeth. This is your clinical situation for a young patient. This is desperate. As well, you see on the radiograph, and if we want to classify these teeth according to their prognosis, maybe Klaus sees it a little bit different. But in our opinion, all of them have either a hopeless or unfavorable prognosis. And if you look at the DVT, then you see the amount of bone loss she had in all areas, also in the frontal area. There's almost no bone. So what kind of treatment should we perform? And this is the traditional treatment sequence. We extracted the teeth, we waited 6 months that we have a real closure, soft tissue closure. Then after 12 months, we implanted. After 18 months, abutment connection. And after almost 20 months, she got her first fixed bridge, and we finalized the situation after 26 months. So it took 2 years almost to finish the case.
When was that, Hannes?
I will tell you in 2 minutes.
Okay.
Look at the beautiful bridge made by our master dental lab technicians, in this case Rainer Janosch, made out of dental ceramic, beautifully finished. Now, normally we would end a case presentation with that, pictures. But wouldn't it be very helpful if we ask the patient, how was the treatment?
Ich war berufstätig, ich bin auch ins Büro gegangen, Schal um den Mund, um den Hals und habe dann nur mit meinen Mitarbeitern schriftlich kommuniziert. Und ja gut, ich hab mich damit...
2 months without teeth, without dentures.
Und mit Höhen und Tiefen. Und ja, letztendlich, wie gesagt, war einfach die positive Grundeinstellung, es kann nur besser werden.
And I asked her, what was the most difficult period?
Was war für Sie die schwierigste Phase? War es Beckenkampf, war es gut laufen oder war es diese Zahnlosigkeit?
Na, Beckenkampf, das war eigentlich gar nicht, sicher waren es Schmerzen, war unangenehm, aber was halt schon sehr beeinträchtigt war, das war die Nahrungsaufnahme. Weil ich muss dann schon sehen, dass, und wir haben immer gesagt, das Gebiss ist aus der Steckdose, weil alles püriert wurde, bis hin zum Schweinsbraten und Pichelsteiner Eintopf, aber es hat geklappt und sicher, es war oft nicht einfach und angenehm, aber dank meines Mannes, der mich auch immer wieder aufgebaut hat, bin ich halt dann immer Step by Step von einem Termin zum anderen.
Now let's see the case and I will answer your question 23 years later, how implants work over time. And you see, there are a lot of implants, long implants. That's the way we treated these cases many years back. But look at the marginal bone level. There's almost no loss at all over this long period of time. So implants work, even in a case like that, which is probably aggressive periodontitis case. Let's go into the literature, and the literature supports this concept. We have very high survival rates with implants, and we also have survival rates with even in augmented bone. This works extremely well. However, if we look into the complication, the technical and biological complications are high. If you look at the meta-analysis of the Greek group, there were only 8% of the prostheses were free of any complication after 10 years. So this is more type of problem, what happened to the bridge. Now let's see what is Irene's point of view. And she's happy with her implants. It's sustainable. It's an improvement of her quality of life, we all agree. However, treatment effort is high. Treatment time is long, more than 2 years. Morbidity is high. She had hip grafts, several surgical interventions. Financial effort is high, and the quality of life during the treatment was extremely low. What changed now in the last 25 years? Now let's go in the year 2012. And I would like to introduce Fred. Fred is self-employed, 42 years old. He lost, as a young adolescent, his teeth were crowned, all. We discussed that this morning. This happened in our country in the old days quite often. And they all ended up being removed. And that is his situation.
Dann wachst du auf, hast keinen Zahn im Mund und gehst heim. Das war die Hölle.
So he told me life turned into hell. He didn't participate in any social activities, no more sports, nothing. He was always afraid that his dentures will fall out, and this is his situation in the radiographs, only 2 teeth left. Now, what can we do today with a patient like that? And you see, this is the concept we are using. We're using the so-called all-on-4, but I like more the term all-on implants. And most of the time, not always, we place the implant in a tilted direction. And we try to anchor as much of the native bone we will find. And the tilting, the angulation, gives us an implant in a more distal, with the platform in a more distal situation, so we don't have to cantilever as much. We need high primary stability in order to primary load the implants and to give the patient teeth in one day.
Es ist bei mir noch unbeschreiblich, grandios, das Schönste nach der Geburt von meiner Sohn.
So extremely grateful, 3 hours after the surgery. And this was the final restoration on 4 implants, the distant one tilted.
Yeah, can you go back? Can you go back one?
Sure.
Yeah, I have 2 questions here. One is about the type of prosthesis that you are showing. It's a full arch, one-piece acrylic restoration. And the other thing is, was there really the need to have tilted implant in the lower jaw?
Yeah, 2 good questions. Now, in these days, we used the traditional way, acrylic denture teeth supported by a metal or titanium framework. You will see later on we changed that concept. And the second question, why do we tilt it? I mean, in the lower, you could also use short implants posteriorly, but very often, if you have low bone quality, it's easier to have primary stability with long implants. And that's why you angulated it. But it's not always, sometimes we do it in a different way, it depending upon the anatomy and the bone quality.
So the real reason for placing this really long tilted implants is because you're going for immediate loading.
Right.
So if you would go for a delayed loading,
you don't have to.
You don't need them.
Yeah.
Okay.
And still, this is a patient that has been using a removable denture since a lot of time.
You mean, yeah.
Yeah.
There's also another way, but it's much, much nicer for the patient.
Yeah, of course.
If I can
Emotionally
give him emotionally, if I can tell him, look, we do one surgery in full anesthesia, and you will wake up, and 2 hours later you will have a fixed bridge. And we can do it. And let's look at Fred's eyes. Look at him. He's so happy with his new teeth. And this is the type of bridge. And if we look in the literature, we get the same survival rates. There's no difference. So this works, immediately loaded, immediately restored. However, these are our own data. We have a lot of own data. We published some of them, but not all. Complication rate in terms of technical and biological complications is high, much too high, we can say.
Yeah, I think this comes a little bit. We have had a lot of question about survival rates of the big bridges on teeth, survival rates on implants. And I think this is the real issue. That is the complication rate. Because like the survival rate Professor Lang was presenting of 92.4%, it means that a big part of the reconstruction is still there. But it doesn't really tell you
about the complication.
About the complication and the shape of the reconstructions. But here we are hearing figures like 40% complication rate, 80, 90, what? Almost 92% complication rates in the beginning.
In the beginning. So it's a bridge. It's a prosthetic work.
Yes, that fails.
Plus the inflammation around implants. And you can see later on, we have ideas how we deal with that. Yeah. And let's go back to Fred. And from his point of view, look, everything is positive. Morbidity now was low, only one surgery. Costs are much lower. It's half or even less. And the treatment time was very, very short. And if we compare the two patients and the two approaches and look at the quality of life table, so there's a huge difference. For Irene, it took almost 2 years to come to the same result, and Fred had it almost, in 3-4 weeks. Now, with that in mind, Wolfgang and myself, we started to change our profile in the clinic. And we discussed a lot, and we used a lot of strategies you will find in startup companies. Most importantly, we gave that message. We can help you in a very short period in time and change your life if you have these problems in 1 day or in a very short period of time. So we did, if you want to, we started to do marketing to spread this information. Why? Because these people are not within the system. Very often they don't go to dentists. And you see the results, the response in the population, in the people. Look, nowadays we treat almost 300 to 400 patients per year. Let's analyze these patients. What do they have in common? Many of them have psychological problems, like fear, they distrust patients, they have no confidence, they had bad experiences, they are desperate. And sometimes, as you have seen, they don't participate anymore in social activities and sports and so on because of a bad oral health situation. And this is an important message for you. In our opinion and what we experienced, these are not edentulous patients. Very few are edentulous. Let's say 5 to 10%, we have data for that. Most of them have still some remaining teeth in a very bad oral health status. So when these patients come in, they're going to address you and you ask them, what is your main complaint? What would you wish? They will tell you, I will want to have implants and nice teeth in very short period of time. So it's a completely different story. They come to you and ask for implants. Now it comes to you as a clinician. And we have 3 categories. And where we say all on implants is the treatment of choice. Yes. We also have the category all on implants is not the best treatment. And we have the most difficult ones, this is the maybe. So let's start with yes. I show you 2 different type of patients. One is Henry. Wolfgang has already shown this patient.
We are really happy that you put the picture of Henry in black and white.
Yeah. I know.
I think it would spoil a little bit the dinner, you know. If it would
this
be in
gives you an idea. And these patients are diseased. You know, they went it's not that Henry doesn't go to the dentist. He has been to the dentist, he got the same answer. We have to extract all teeth, it will be a very long treatment time, financially demanded, so he went back home. And, you know, and more he came into this status. And if we look at the radiographs, this is periodontal disease. Most advanced periodontal disease. He's a very intellectual person. You know, he writes poems during the day, and in the night he's working in a postal delivery. So we changed his life. 1 treatment, 1 day, delivery, and after 4 weeks he got his new teeth.
Hannes,
Yes.
before you go to the next case,
Yeah.
let me ask you something. Aren't you scared about transitioning a patient with such a poor oral hygiene
Yes.
immediately
Yes.
into a fixed implant-supported restoration?
Luca, this is a good question. We were very scared. And that's why we looked into our 7 years data, and we had all patients you will see later on. I will show the black indices, and you will be surprised because they start to brush. Why?
Because they're happy.
Because they are happy now.
Yeah.
You change their life. They participate again, you know, in the social environment. They do sports, all kinds.
But still, this is not. I don't think that you can promise to yourself
No.
that this guy would
Yeah.
would improve
But,
so much.
you know, it's like a smoker. If you treat a smoker and he has lung cancer, you take out 1/2 of the lung, you can't, you know, maybe he will smoke again, but maybe not. You give him a chance, and that's what we do. And because, you know, it's financially, they have to invest a lot of money.
Because
I always tell them, if you invest and you stop, you know, and you are not compliant,
the other
you can
option,
throw your money away.
the other option could be to keep those teeth for a while, and help the patient with the plaque control, and then go to.
I don't think that will work. They want to start from de novo. You know, it's psychologically, it's very critical. You know, they have pain very often, it's mobile, you don't change really the situation. And this is a completely different type of patient. This is Hildegard. She's 92 years old. Very intellectual patient. Look, she has problems in the mandible. And if you ask her, she will tell you, I cannot chew. My teeth in the mandible are painful. I have pain for the last 3-4 weeks, and I cannot chew. And the family comes and so on. She's a famous person. You see her here, she's a politician. On the right picture, she speaks with our Chancellor, Angela Merkel, and Alice Schwarzer, head of the emancipation movement in our country. Very nice lady. She was leading the Liberal Party for a long time. So, and when we ask her, what do you wish? She always say, I feel too young for a removable prosthesis. I want to have fixed teeth. And that's what we did. Hildegard, 92 years old, full anesthesia, one surgery, 4 appointments. 4 weeks later, the treatment was over, and she went back in normal life. She was extremely grateful. She delivered to us her biography and with a dedication and saying that in lifelong gratitude from your oldest implant patient. So, the third, let's say, category of patient is the maybe category. You don't know what to do, and finding the right solution it's extremely difficult, but we have to do it as you in our profession. And I would like to show you Monica. She's young. She's 30 years old. A lot of psychological problems again. She went to different dentists, and this is the result. She was desperate. She lost confidence in our profession. And she was very intelligent. So this is the radiograph displaying the amount of bone loss.
So we will not ask Professor Lang whether he would keep these teeth or extract them, because we give it for granted. But
so you see right away that some teeth are not maintainable, others might be. In the lower, you have more problems than in the upper, and now it's your turn.
For the vote. So now we would like to have your opinion again. We don't have all the probing pocket depths. You get a little bit the idea from the X-ray and from the clinical situation. And what we are concerned about here, whether we should really totally work with the teeth or whether we should extract and go purely on implants, or see maybe a combination of teeth and implants is the most reasonable solution.
and we are asking you to vote both for the upper and for the lower jaw.
Yeah. Look at the upper. It's more type of horizontal bone loss. One aspect is she has a very high smile line. She's young. She's good looking. She wants to have a nice aesthetic result. And we have some more problems on the lower. You have one incisor, which lost a lot of attachment, as you can see. And we have in the molar area, you still have totally destroyed teeth by caries, by periodontal support, and so on.
What do you think, Hannes? Do you think we will get different treatment plans for the upper and the lower? Or do you think we will have more or less the same?
I think we got different ones for the upper and lower. I will tell you what we're going to do, but I think when, we have to ask, is for her all on implants in the lower or upper, is that the best treatment solution?
Which one do you want to see first? Which one would you start with?
The lower.
Upper or lower?
Lower.
Lower.
I hope it will work.
Okay. It does.
Okay.
All on teeth, 12%. All on implant, 22. All on teeth implants, 66.
So we have, it increased to 23% now. So I think we move to the other ones before everyone goes to the implant solution.
All on implants is increasing, so every fifth will extract. Now let's see the upper.
This is the lower. Okay, we go to the upper jaw.
Yeah.
Okay.
It's
totally
okay,
different.
yeah. She had more teeth in the upper.
Mm-hmm.
So I think we have quite a reasonable group of people in here.
And I can tell you, that's more or less how we see it. I will show you the result.
Yes, now it comes.
Okay. That's what we did. We did just traditional periodontal treatment, non-surgical treatment. We cleaned the teeth. We did it also under IV sedation. She was not treatable in the normal way at that time. And then we kept the lower incisor too, so we didn't extract in the anterior area. And in order to enhance the aesthetic, we just worked with composite. She also had a financial problem, so that is the final radiograph. And in the lower, you see, she just has the anterior dentition, so definitely in the lower, she needs implants. But she didn't want to. This was the final result. No implants in this case, but I think in the near future, we would place 2 implants in the lower, probably in the upper, in the area here of the first molar, we wouldn't place an implant because there's no bone. We would have to augment. She had this missing tooth for a very long time without any.
So to the ones that we're suggesting for the upper jaw, all on implant treatment for this case, here we are clearly giving this patient a second opportunity. So hopefully in 20 years, then we can go for implants.
I talked to Bjarni about that. I think if she's clean, if she's compliant, this is a lifelong restoration. She will keep her teeth all lifelong. And don't forget, if you look at this picture and you go for all on implant, you have to cut away a lot of bone. You know, look at the transition line. The smile line is so high, so if we want to hide the transition between the fixed bridge and the mucosa, we have to take away a lot of bone, or we keep the teeth. This is also, but this is, you know, it's very.
Or you could also place the implants in a proper way, straight implants, and just have a regular emergence profile.
This is a really demanding type of.
Yeah, of course, absolutely.
I agree on that. Last patient, Herbert. I know Herbert for quite some time. He's a very open-minded man, retired. He loves sports. He's always in the mountains, in winter, in summer, with his mountain bike. We go from time to time skiing. And he addressed me in that I have problems with my teeth, especially in the upper. I lost many teeth over the years. I had from time to time some treatment, but it didn't help. I have bad breath. I think I have a lot of inflammation. I hate my removable denture. And he lives away from Munich, 600 kilometers, and he has some financial limits. This is also very often the case. We have a lot of patients with financial limits. We can't always do what we want. So this is his situation, to give you just an overview. We will analyze this case more in depth, but he had received 1 implant and then treatment stopped somehow. So this was inflamed over time. He lost a lot of periodontal support in the upper, so the teeth were loose, high mobility, and he wanted to have fixed teeth. He had root caries in the molar on the left side, and in the lower, there was also most advanced periodontal disease. However, these were more of type of vertical defects. The tooth number 3-3 was really almost no more attachment, as you can see. We have an apical lesion and we will analyze the bone situation. You see the DVT. Just to give you an idea, can we place implants or not? Is there enough bone? Do we have to augment in which areas? And give you more information. This is the clinical view. So you see he has a bridge on the lower. We have already seen on the radiograph. It's not very nice. He has very long teeth. He lost a lot of support, and then he had quite a lot recession in the upper and the partial denture. Now, again, we have to ask, when is the implant the better tooth if we go tooth by tooth? But we also have to ask on a patient level, when is all on implants a better choice? This is sometimes a different question, because sometimes we end up with 2 or 3 maintainable teeth, and we still have to ask ourselves, should we maintain these teeth or should we extract them? So now it's your turn. Look at the upper and look at the lower.
So,
Advanced disease, mobility. The bridge on the lower was always grade 2 mobility. There was not enough support, especially on the left side.
So now we need your help again for this patient. We are giving you the same treatment possibilities, all on teeth, all on implants, or the C, all on teeth and implants. We have got some complaints here that we are not suggesting full dentures. Sorry about that, but we are really specialized in fixed reconstruction, so that's the reason we don't offer the possibility full denture, so you just have to then vote that for yourself. So I think, so now we have a little bit different situation in the upper jaw and in the lower jaw.
How would you restore the upper jaw, all on implants, teeth, and how would you restore the lower jaw? I don't know if it's in the question.
Yeah, there should be 2 questions on there. One question is for the upper jaw. That is question number 3 of Professor Wachtel's presentation. And question number 4 is the last question we are going to ask you tonight.
So,
is the lower jaw.
In the lower jaw, the critical element is the left cuspid.
Yes, there's some more, you know, it's also but the most critical element, yes.
Yes.
But what about, are you not concerned now his experience with this one implant is definitely not very positive?
No. But, yeah, that's true. It's also, you know, if you also have to consider aesthetics, you know, he wants to have a nice result and the mobility in the upper.
Should we see what people voted for?
Yes.
We start, I think, with the upper jaw.
Yeah, we start with the upper. Okay. Only 5%. 46 all on implants, and the other half all on Ds.
Klaus, may I ask you a question? It was clear that to have an all-on-teeth solution in the upper jaw, you would have to have cantilevers. Would you still plan a prosthesis with 2 or 3 elements as cantilevers on teeth? Okay, okay. He's a courageous one.
We got 5% for all on teeth and upper. That is Klaus. I didn't know that you were so good with the apps. That you voted on this. No.
You're asking me a question that has with technical issues about cantilevers. But if this makes sense, yes, why not?
Okay.
The alternative being bone augmentation and what have you, you know.
Yeah, you definitely need, in the first quadrant, if you want to place implants in the traditional way, you need bone augmentation.
It always is a good sign if you present a case for the audience and you get about 50-50 outcome. So it means this is a good case for discussion.
Presentation.
Should we see the lower?
Let's see the lower. Yeah, it's a different picture. Only 25% would extract
everything.
All teeth, definitely for 24. All on teeth, 22, and implants and teeth.
So the majority of the people here in this case would have kept some teeth and used the implants. Okay.
Yeah.
But what is interesting for all those 3 cases that we have been voting on, those 3 large cases, we have had all on implants. I think it has been between 22 and 24% for everything. Do you think we have the same group always voting for the implants? So they are really just stuck.
Yeah. Maybe.
So that must be all the endodontists that are in the room. So I'm not hitting on any specialty. So we keep it to the endo.
One question, Hannes. Now, we heard Klaus' opinion on this topic, but what about yourself? If you have to go for teeth and implant, a combination of the 2, would you ever connect teeth and implant with the same framework?
No, we don't do it on a regular basis. We always try to avoid it.
Okay.
you know, if something goes wrong, you lose an implant or something, we might, but and not on a regular basis.
I think that's
We
a very important.
keep very separate units.
That's a very
But
important.
what you could really do is with your implants, you can stabilize the whole dentition if you have teeth with loss of periodontal support. So if you have, you know, teeth and implants, it will help, you know, to stabilize the dentition. Now let's look what we did. Okay, can you go into the presentation
It
again?
should be
You're
the-
out.
No, it should be the presentation.
Okay.
Okay. And you see right away the upper. So there were about half of it. We extracted all teeth. We extracted the implant.
But this you did in a staged way, so you had already placed the implants in the molar area.
No, this was the old implant. We removed the old implant,
okay.
and then we leveled the bone. This might be a point of discussion later on, but this is
Yes.
extremely important to do that, in our opinion. Then we look at the anterior wall of the sinus just to have a better understanding of the anatomy, and we start to place the first implant in that angulated direction into the bone. We did the same thing on the right side. Always we stay within the native bone, but we want to have the platform in the most distal position in order not to cantilever
Do you
too much.
think it would be an advantage to do this today in a guided surgery?
Yes, you could. Advantage not, it depends. You know, we are, let's say, everybody of us, we did several hundred cases, so we are very experienced. But if you're not so experienced, then it might be an advantage. It's not so easy because you have to reduce bone. But there are some new ways, Straumann has a new way and other companies, you know, to address that. And because you need two splints and things like that. So technically it's not so easy, but it will come.
You also need an experienced prosthodontist to deal with those angulated implants.
And sometimes our opinion is if you have, you know, we're doing a lot in atrophic bone. We do cases where 10 years ago when we started, we never thought we can do that. So, but today, you know, with all the experience we gained, and then I have to say that what we get as a result out of the digital tomography is not precise enough. Anatomy, if you see the anatomy and the amount of bone, there might be a change of 1 to 2 millimeters, and that makes a big difference.
Let's see what you're
Lower, we are periodontists, so the lower we kept all the teeth. This is a papilla preservation flap, like most of you know. Then we took the bone, we took from the upper to fill in the defects with autogenous bone. So we had enough bone. We used enamel matrix protein, and then we closed the situation. Here you see the bone. In one area around the cuspid, because the defect was huge, we used a collagen membrane. And sometimes we use as a material, it comes from Technos, Italian company. This is putty, a lot of collagen mixed with some phenogenic bone, which is resorbable.
So you did like upper and the lower in one session?
In one session.
And the patient was asleep?
Yeah.
You put
Full
everybody
anesthesia?
asleep, huh?
Yeah.
We have to be careful.
Yeah. Oh, it's nice. Yeah.
It can be. It can be.
So
I can assure you I don't have the probing depths, but we came in, it's over 2 years back. He has, in the lower, he has no probing depths exceeding 3 millimeters. It was almost, he's a very good cleaner, very high compliant. So that's him 3 hours later. You know, laughing, he has his new bridge already. We call it the first bridge, made out of acrylic. And that's a new way how we fabricate the final bridge. We will see later on, it's made out of zirconia, it's CAD-CAM technology. We still use some acrylic gingiva, but it's multi-layered zirconia, 2 types of zirconia, and it's extremely aesthetically pleasant.
So it's nice to hear that you have abandoned full acrylic
Yeah.
restoration.
Look at him.
This is 24 hours later?
No, 4 weeks.
Oh,
This is the final bridge.
oh, the final.
He likes it very much. Now, at the end of my presentation, I would like to address the two topics which are in the literature and which happened also in our clinics, and these are the complications. First, what can we do with the technical complications?
Leave us sometimes to discuss the bone resection. That
Yeah.
would be a hot topic.
I've only-
Yeah, you have time.
I've-
You have time.
So we opened a new way of fabricating the bridges, and this is the digital. We are almost fully digital. There's another problem we had. We had to I would say, we had to train our technicians because these are always full mouth reconstruction. And a lot of our technicians come from the denture side, from the acrylic side. But now they work in full mouth reconstruction, so there was a lot of training. And we work with the plane finder and with the face hunter of Zircon-San and the software. And this is what we have achieved. So we have different types of zirconia. One zirconia is a frame width with a high flexural strength of about 1200 megapascal. And then we have single crowns, which we glue to the framework. And then these are multi-layered, different type, multi-layered zirconia. So basically, this restoration bridge is made of zirconia, and still the gingiva is an acrylic, and we might change it in the near future. Now, look what happened in our hands. The complication rate in the first with the traditional approach, acrylic and titanic framework or metal framework, was high. Fracture rate was almost 15%. This means a lot. And then look what happened. These are data based upon almost 200 bridges. These are only now 1 year data, or 1 year and 4 months. So it's not long term. But you can see that the fracture rate went down lower than 3%.
That's very nice to see, and
Yeah.
it's also a very effective approach, because if something goes wrong, you have to deal with one small restoration.
And we have the data. So if the patient calls us and say, we can ask him, it's a front tooth, left side, right side, and we can make the crown right away because we have the data. He comes in and we just change it.
And you say that you are not increasing your cost too much with
No,
that?
not at all.
Well,
That's the same
I think
cost.
in some places around the world this
Yeah,
would be
we-
very expensive.
But what we could see, because the time to fabricate the prosthesis is by the digital workflow reduced by 30%. So we could keep the same amount.
I think a lot of the questions that we have gotten from the audience are exactly on this topic, maintenance.
Yeah.
If I first, Klaus, ask you, the cases you showed, or the patient with this full arch bridge on teeth, what would be the maintenance program for this patient?
That starts out quite intensive, a recall frequency of maybe 3 months. But then we work with the data of the patient. If the patient has low bleeding on probing scores and no pockets, he goes to 4 months, to 5 months, to 6 months. Some go up to 8 months. So the recall frequency is tailor-made, and it depends on how the patient performs. So with her or his own data, we would determine this. A recall hour is always starting with some diagnosis. We look at bleeding on probing on all teeth and also the probing depths. Then we would say, well, okay, we will, from the bleeding sites, we would instrument. Today we would use air powder devices. In maintenance cases, airflow. And then we would very deliberately scale and root plane where we have inflammation. So it's a little bit tailored to the thing, but the key issue is to get people down to low levels of inflammation.
Thank you.
So now I think we have to see, is it easier to maintain those patients where you have restored everything on implants?
I don't know. We don't never have a control group, but they have to clean, and they learn how to clean. And what we did in order to motivate these patients, we give them a 6-year warranty on the implants. We started with 10 years, but this was a legal problem in our country. So they have a 6-year warranty if they comply. And we start with 3 appointments per year, and they should be non-smoking. And then when they come in, and it's extremely important that they can clean it. And they can clean it much better if you have a flat surface. And this is also a reason for bone reduction. It's a cleaning. You know, we have a very flat surface. You can see that over here because we flatten out the bone. And then cleaning becomes much easier. You know, they enter with superfloss and clean.
We have Klaus there that wants to complain.
Hannes,
Yes.
I think you should add a very important step. I know you don't like to rose yourself, but the reconstructions have to be cleansable.
Yeah.
And if they're not, then you create breathing.
Everything
areas.
is lost.
Yes. So your guarantee can only be because you also perform it prosthetically correct.
Yeah. That's otherwise we use a zirconia base with data showing that it is easier to clean. And look at the black indices. This comes out of the 7 years later. I said, Klaus, and you asked me, do they clean? And you see in average, we have a high standard deviation. Sometimes they do, sometimes they don't. But you see this, the median is between 10 and 20% of the surfaces.
That is
and
nice.
This is very high. And this I said, Cortellini and Maurizio Tonetti, they don't have better values. So they clean.
That I don't believe you.
And Hannes.
Come and look, they invested so much money.
I mean, if you show that your average is this plaque scores.
Yes.
Plaque scores is below 20%.
No, I said in the median. You know, sometimes it's a little bit higher.
Yeah, okay. But generally we can say plaque scores below 25% are acceptable. But bleeding on probing should be below 20, if not 15%. And then you just got to work with them.
I mean, the data were not, you know, these were the dental hygienists. They collected the data. So probably they only have 4 implants per jaw, most of them. So let's just finish, Herbert. So now would I like to finalize and finish my presentation with 3 take-home messages. The first is, most of the patients we treat with this concept and we see set up in our clinic are patients with teeth, not edentulous patients. And that changes the whole story. Treatment planning is complex, and it has a goal to improve the quality of life of our patient. And our decision-making process is guided by a quote from Bjarni. And we did this already 2 years ago, and this was the final conclusion. You have to be a periodontist by knowledge and by heart to do all on 4. Thank you very much. Thank you.
So maybe we just keep those the final words of the session. I think Professor Lang, he usually puts it a little bit in another way about the nail and the hammer.
Oh, yeah.
So I think it's a little bit the same issue. If you are practicing those methods like some people call all-on-4 or all-on implants, I think the real prerequisite is that you know how to keep the teeth. Otherwise, everything will just fly out.
Mentioned, our two speakers are being transferred right here at our desk, where I'm joined by Isabella Rochetta, who's been with me throughout the session here.
Yes.
For the viewers who just entered, you are part of this community and you've been watching, looking for the gray area, you said beforehand. So it's clear on the one end, on the other end. What have you taken away from this session so far?
Well, first of all, I'm very much looking forward to having the speakers here with us, because I think they have addressed, in a way, very opposite directions, which is obviously what we're expecting. With Professor Lang showing very long-term maintenance of extreme cases, which I must say are very fascinating to see what biology and what nature can give you. On the other hand, obviously, we have to be pragmatic. We have to think of what is valuable for the patients, and I must say the quality of life that was very well described you have to take it into consideration. Having said this, I'm looking forward to having them, because I would poke them a little bit in the gray zone, because they have shown, apart from the last case, which was a gray zone case, they've really shown extreme cases. The extreme cases, paradoxically, is easier to have a treatment
to
plan.
make a decision.
To make a decision.
Yeah. And at the same time, let me also welcome you as online audience. If you joined later, we are here to actually ask your questions on your behalf. And I see already quite some questions coming in. Keep doing that in the comments. We have a question ready from Klaus Höcker from Germany, Taratip Weerapan from Thailand. Good to have you with us as well. Philippe Vieira, I got your question written down from Portugal. And also Manas Shah just posted a question in the comments. So keep doing that, because the speakers are on their way to this place, to this forum, and I'm also inviting the people around us here physically. You can also ask your questions to the speakers when they come in. Now, to cover the gap between the speakers getting from stage to here, maybe it's nice to you as EAO Online Congress delegates to actually show a little bit about what it looks like if you could have been here in Vienna. So this morning I went out to record a little video and show you around. Let's have a look at that clip. Hello and welcome here at the Messe Wien in the heart of Vienna, where the EAO Congress is taking place.
I did.
The layout of this year's Congress is very compact and easy to navigate. In the heart of Hall A is the exhibition area where the lunch and networking breaks take place. Around the edges are all the big lecture halls, and right here at the front is the EAO booth, the digital village and the forum. Let me show you around. This is Room Wien, the largest conference hall, which fits all 5,000 EAO Congress delegates. And this is the stage where we broadcast all the online Congress sessions from. In the digital village, EAO delegates can access over 500 abstracts. They can easily navigate and browse. They can digitally contact the authors for their questions or further discussions. And here at the forum, we have live discussion about important EAO projects, both with an audience on site and online. And that's where we broadcast those sessions. So I hope that helped you to get a little understanding of where we are here at the Messe Wien in Vienna, with almost 4,000 delegates from all over the world, and it's very exciting. And we'll do our best every day, twice a day, with a live broadcast here on Facebook to capture some of the key insights and to actually make sure that you can make the most of your potential as well. So make sure you like the EAO Facebook page. When you go on the page and it says how to follow them, make sure you want to see the posts of EAO first. Now, Isabella, still with us. When you walked into the room, you said, I hope they cover the gray area, and I hope they show me some practical advice on the diagnostics, right? Once in the clinical practice, what should I look for to determine to go for the tooth or for the implant? What have they shared with you there?
Well, I must say listening to Klaus Lang was very refreshing because, as I said before, you know, he's a little bit of a father of periodontal treatment, I would say. He obviously showed, as I said, cases from, I think, 1970 something, with a very extensive periodontal charting, which gathers, it's a diagnostic measure, obviously, that you must have. They haven't gone into the multidisciplinary approach. What I would have loved to see as well was all the prosthetic planning, because what I've seen was very surgically oriented from both sides.
Yep.
I would like to ask them personally about, you know, all the prosthetic planning beforehand and understand a little bit more in terms of occlusion and in terms of final results, because we all work backwards with a final end result in our minds. So this is certainly something that I would have loved to see a little bit more.
Because how would you define some of the key challenges there? What are you running into?
Well, you're running into loads of factors which then make, you know, the whole treatment plan be a success or a failure. So it is a very much of a multidisciplinary approach. We, for example, in our clinic in London, we sit together once every 4 weeks to gather all the complex multidisciplinary cases. We spend a lot of time throughout the evening to go through all the options with a team, which is obviously a multidisciplinary team, from the endo to the restorative, to the pros, to even to the orthodontist and so on. Because only by putting multiple brains together you can get to a final result. I very much, you know, like the presentation that Professor Wachtel was showing. However, I am a little bit concerned because it appeared a little bit too easy and too quick.
Yeah.
Which is a message, especially for the young ones, that we want to come across. Now, it looks as if, why not? Extraction, 4 implants will hold everything in place. And I'm very scared because this has been multiple times addressed in various meetings. And you really have to be cautious in selecting really the appropriate case, which again is a 360-degree from a patient point of view, from a case point of view, from a periodontal point of view, and B, even from a surgical point of view, you know, removing significant amounts of bone is something that breaks my heart.
Yeah, and it can be undone, right? It's once you're out, it's gone.
Yeah. So I understand there are specific indications. I don't want to absolutely say the contrary because I'm not in the position, but certainly it is something that I listened, I was in the middle really of the lecture hall. It was packed with people, which was brilliant. I was in the middle and I was hearing the comments of the people around me, and again the comment was, oh well, yeah, everything sounds kind of a lot very much straightforward, whereas I want to know more about the complications, about the long-term maintenance of these patients, which was slightly addressed, but I think
maybe
there's a little bit more to it.
Well, I see from the corner of my eyes that our speakers are here already. Mr. Wachtel, you can join us. Please grab a microphone. Good to see you as well. This is where the whole thing becomes live and interactive. Speakers walking into the session. Also, to those of you here around us, if you have questions for our speakers, please feel free to join in. What did you do to Professor Lang? Did you leave him at the stage? Oh, there he is. There he is. Okay.
He met so many friends.
Oh yeah, let's go. Because our online audience
on the
is
ring.
hungry.
Yeah, he met a lot of
Professor
friends.
Lang, good morning.
A lot of friends.
Well, good afternoon.
Please use the microphone. Yes, it's on.
Yeah,
yes.
can I make a comment?
It's on.
It's on.
Klaus, just talk into it. Yes.
Working.
There you go.
Is it on?
Yes.
So where is the fight? Where's the blood?
You guys
Where's
are
the blood?
hugging too much.
Well, the fight. Nobody will profit from a fight.
Thank God.
Because it gets emotional. That doesn't mean that we fully agree. Specifically, I was asked, what would you do there? And there was a case where I would have chosen another way. But I can rationalize what Hannes Wachtel thinks why he does this. The question is it always like that? Is this a prototype treatment that you get with Hannes and you get a prototype treatment with me? That's not the case.
Exactly. Life's not that simple.
Yeah, no, we have selected cases that extremely are suited for this discussion.
Exactly.
But it does not mean that we have a standard that is right and a standard that is wrong.
Exactly. Now let me quickly attune to our online viewers. As you can see, we kept our promise. Our speakers are with us here in the forum. Also to all our audience here at the forum, if you have questions to our speakers, please raise your hand. I have a few questions lined up, but I'm going to give the floor first to Isabella Rochetta, because you said, I'm looking for the lessons in the middle. You guys were too much on the extremes. Isabella?
No, we were just discussing, and we would like to address this to the audience who's following us, who were lucky enough to follow your amazing lectures. Well, you know, it would be interesting to understand in the gray zone, like your last patient you showed, which was a clearly gray zone because you could have various options. We also want to know, for example, the long-term maintenance of these patients, as you addressed, and as I was commenting before, it almost looked extremely straightforward. A message that came across, and I was sitting in the middle of the audience, was, well, that almost is too easy. So it was almost like I want you to make the, for example, young audience aware that it is a very thoughtful process coming from a lot of experience and background and literature and prosthetic setup and so on. So
I completely agree. It's first, decision making is very complex to find the best possible solution. And you have seen in the voting, you know, these are all very interested, good dentists from all over the world. There were different opinions. There's no black and white and no right or wrong. We look very closely, you know, we look at the teeth. We ask ourselves, when is the implant a better tooth? This is where we start. But then we add a lot of different factors and aspects. What is your quality of life? Do you have time? Do you have the money? All these things play an important role. Aesthetics. Can I give the patient the aesthetics he wants to? And then we decide either way. And coming back, it looks easy. You know, if you put everything into one surgery in a very short treatment time, it becomes extremely difficult. So I always tell our students one sentence: time is not your enemy. But for the patient, that's a different story.
Yeah.
If you come to a physician and he will tell you it will take 2 years and 25 appointments, you will ask right away, do we have another way? I'm a dentist.
Can we do
I'm
it
very
faster?
busy. Can we do it faster? And I say, yes, there's a way, sometimes, not always.
But there are treatments that take 25 visits, not in dentistry, but an oncologist tells you you need 25 irradiations, and there is no other way.
So what are you saying, Niklaus? We shouldn't be too scared of that?
No, I think that's not the major issue.
Yeah.
But I think you asked for messages in the middle. I think what we both have not spoken about, but expressed in a way, is that implant therapy is part of the therapy of a patient. It may materialize that you use implants or you don't, but these patients need comprehensive dental care, and they need to be treated as infected individuals, which brings you to the maintenance afterwards. You need to change the paradigm of the patient. Whatever you do, whatever house you construct on teeth or on implants, you need a solid foundation. And I think that came through. On the other hand, I was very happy to see that Hannes Wachtel has not really presented all on four as it is propagated. Namely, he has taken mostly patients that were almost edentulous.
yes.
Not that he takes out teeth in order to put in implants. I mean, I always say implants are not here to replace
Yes.
teeth. They're here to replace missing teeth.
Missing the
And I
gaps.
think that was beautifully in his presentation. They were either already close to edentulalism or
Yes.
had 2 teeth left or so. That's a different story than if you still have a dentition. You know.
Exactly. Exactly. In the little preview show, we used the word abuse, which was echoed in the online comments as well. Abuse dentistry, and that's what we should stay far away from, right? That's what you're saying as well. When you say the importance of maintenance and treating these as patients, let's take a few very practical questions from our online audience. We have Mana Shah, who has a practical question to you, I guess. Do you remove, let me read that correctly, would you remove the superstructure every 6 months
Okay,
with the
good
maintenance
question.
appointment?
Very good question. We started to do that. We started to remove the bridge 3 times a year. Then nowadays we do it in a different way. We look with the floss. We floss the patients around the implants. If there's bleeding, you see it right away, we remove the superstructure. We look what will happen to the implants. Because we didn't discuss that, but with tilted implants, it's very difficult to probe.
Yes.
As this is one of the big disadvantages. But on the other hand, you have to remove it. If there's no bleeding at all, and it all looks very clean, then we don't remove it. We do radiographs depending a little bit of the patient, but every 2nd or 3rd year, not too often.
Not every time.
And we have a frequency of appointments in the maintenance. We start with 3, we go down to 2 after 1-2 years, and maybe even 1 if the patient is a number 1 cleaner. And they are sometimes, you know, we have patients that clean perfectly well. You will not find any inflamed mucosa around the implants.
Perfect.
Of course, my reconstructions on teeth, they cannot just be taken out.
Of course.
Exactly.
So the problem is, or the dogma is, that you need to make the reconstruction
Cleansable.
accessible to oral hygiene.
Absolutely.
Cleansable. And we have addressed this also on stage. But it is so important because when we see peri-implantitis, we see in, I would say, 50% of the cases that the reconstruction is not, quote, hygienic.
Yeah.
Exactly.
So I think you can leave the reconstruction in the mouth, provided that you have access to all the areas that have to be cleaned. And I must say today, industry has provided additional ways and means to improve that daily cleaning or the professional cleaning with air powder devices and so on that are very effective.
All right, so we have some very clear
I would
practical
just
advice.
add
Yes,
one
build on that.
sentence. It's especially true what Klaus is saying, that especially for the fixed bridges on implants, they have to be cleansable. And we see quite often the opposite. We have to admit that. So there must be a very, effective education of our colleagues, not only how to place implants, but how to place reconstruction which the
Have a
patient can
durable
clean.
solution. Yes.
Otherwise, it's a disaster.
Well, Mana Shah is saying thank you from the other end of the world. So this is working. Let's take another one. This came in when you were still on stage. It's from Klaus Höcker from Germany. And he was wondering how these patients, so I think he's referring to your cases, can control the biofilm.
Exactly like any other person.
That's not an issue, you say?
No, the biofilm force on all hard, non-shedding surfaces in a fluid system. That can be the tooth, it can be a crown, it can be an implant, it can be a prosthesis. So to control the biofilm means to remove it.
Exactly. And that's the same.
That means
doesn't
special attention to all the areas. The more elaborate dentistry you place, the more bridges, crowns, pontics, and so on, or implant-supported reconstructions, the more they need to understand that you cannot let that go.
Exactly.
It requires, I would say, at least 3 minutes, at least 3 to 5 minutes per day.
Fully agree. That's what they invest a lot of money in their, when we reconstruct the bridges. And I always tell them, you can throw your money away if you don't clean.
Yeah, you were saying
It's
this.
just, it's just like nothing.
However,
So complete dentures is better if you don't clean.
I had once a case, a university professor, chairman of a neurosurgical department. He was saving lives every day, but he could not use a toothbrush because he was too lazy. Then I had an American hygienist who was
changed his life.
completely devoted to the job. And she did not have any inhibitions. She told him, okay, if you don't do it, you come to me every week.
Yeah.
And he agreed. As to go to the hairdresser, he came to be cleaned.
And after how long they got married?
Well, after 2 years when she left,
I told you.
they didn't get married, but he had lost his teeth.
Okay, so she didn't succeed, unfortunately. Isabella, you wanted to step in, I felt.
Yeah, no. I was going back to what we were discussing about complications. Tell us a little bit more if something goes wrong when you use 4 implants. Let's say one is
let's
lost.
see.
What happens?
There are a lot of things can go wrong. I mean, first thing is you don't get the primary stability you would like to have.
Sure.
Then you can't load the implant. That's easy. What we're going to do, we place an additional one. Maybe sometimes we do it the opposite. We use that implant, which is not, let's say, over 30 Newton, and we place another one, just for security reasons, because it might not survive, but we have a second one.
Okay.
So all on 4 is,
Just
then
Hannes,
we have
when,
all
when
on
you
5.
say this very easy, then we place another one. Is this in the moment in surgery or
In
the next
surgery,
treatment?
in surgery.
Okay.
We decide in surgery to place an additional implant. But sometimes, it's very seldom, we are so experienced, but sometimes it's also the case we can't load it. Then the patient has to go with a complete denture. We tell the patient in advance, it's very seldom, I would say, it happened to me in the last 3 years, would say 2-3 times.
Okay. What about the
And then long term.
long term?
What can go wrong? The complication then later on is mainly technical. We get fractures. And we were really working hard on that because you have all this treatment done and then, very often it's the same patient who comes in, first fracture, second fracture, is a patient who abruxa. And then he get very disappointed. That is a big problem. So we worked hard. We changed the approach. We changed how we fabricate, and we came, as you have seen, more and more close to another solution. It's not only the material. It's also the approach of the dental technician. We went back a little bit to what we call knausology. In the old days, occlusion, articulation must be perfect because it's a full mouth reconstruction. And then we have the biological problems. We have periimplantitis, as low percentage. We have. And most of the implants, if we have advanced periimplantitis, we take them out. We place new ones. We don't keep implants, sometimes, let's say, some say 1/3 of the implant or so. But if we are, let's say, if we are 2, 3, 4 millimeters down, then it becomes a problem. You have the rough surface exposed and stuff like that. So for us, very often it's easier to take it out, place a new implant, make a new bridge, and it's cost-free for the patient.
Exactly.
Within the
Within
6
the
years.
6 years, as you were describing.
Within the 6 years, guaranteed. It's 6 years. I quickly want to take one of the final questions from an online viewer, which is Taratip Veerapan. He's from Thailand, and I think his question tries to conclude us to some kind of guiding design principle. He says, due to the high survival rate of modern endodontic retreatment and endodontic microsurgery, should we keep natural tooth, adequate tooth structure, he means, first, before implant treatment? So it could be a
The answer is yes.
Yes.
Echoing.
Do you even agree, Wachtel? No.
I would say yes, but
Yes, but.
there's one aspect to that. You know, every treatment, the patient has to invest money. And if we can do that without investing a lot of money, what we can do very often in perio treatment, we don't need surgery or that very often, then it's perfectly right.
Yes.
But if we go to more advanced types, let's say hemisecting the tooth and stuff like that, we have to have a good prognosis.
Of course.
Otherwise, you know, it's not feasible. But in general, 100% delay the implant.
All right. Well, with that, I think we come to the official ending of our broadcast, but not before. I thank you very much for staying with us, for being so active, for sharing this video with around the globe, and to invite you to some of our other Facebook Live broadcasts that we have lined up for you here at the EAO Online Congress. Make sure you tune in tomorrow morning at 8:30 Vienna time for a breakfast news session. We'll have a chat here at this desk with Michael Payet, one of the co-chairs of the Congress, and he'll be joined by Ueli Grundner and Ist van Urban. And we talk about the state of the EAO community. We talk about what they've seen at Congress so far and what their dreams and their reality is for implant dentistry. And then tomorrow, around the same time of today, 3 o'clock Vienna time, we'll be back with another battle of the concepts where we look into how much time do we have. And the battle going on is whether we should always go for immediate or we should always focus on late implants. Well, lots more to come. Thank you for staying with us all the way to the end. Make sure if you know anybody who's interested to learn more about the future of implant dentistry to share this video. Follow EAO on Facebook and you'll be the first to join us again tomorrow. Thank you.